Good evening, ladies and gentlemen. Tonight I'm going to teach you about superoxide radicals. No, I really appreciate, and I hope you appreciate as well, the opportunity that we have had to be taught by some very intelligent people and some people that have done some extensive research on patient blood management. And I just want to let you know that tonight they asked the token orthopedic surgeon to come and speak to you to dumb it down a little bit. So we're going to talk a little bit about orthopedic patient blood management, how we can best utilize it, and how each and every one of you, if you ever need orthopedic surgery, which unfortunately we're all mortal and we wear down. And so at some time in your life, you will probably need some type of orthopedic intervention. So I'm going to talk to you a little bit about how I came into the patient blood management and what I believe we can do to really accelerate this and carry the torch with patient blood management. Okay, if I can get this to work here, let's see. Okay, that's what I meant by dumb it down. I'm sorry, I messed it up. If I can kind of have that back here. I think I just need to push the arrows here. Okay, let me see here. Okay. All right, we're going to move along here. I'm going to talk a little bit about joint replacement. And the reason I'm going to talk about joint replacement, hip and knee replacements, is because it's the primary procedure that is performed here in the United States and throughout the world that does require blood transfusions and blood interventions. There are more than 7 million people in the United States right now in our country that have had hip or knee replacements. And approximately 1 million of you will undergo hip or knee replacement in the next year. So it's a pretty substantial amount. These numbers are obviously expected to grow exponentially because of the baby boomer population, and we're just kind of coming into that in the mid-60s, and so it's actually anticipated to grow quite a bit in the next few years. There are a few factors that are associated with hip and knee replacement and patient blood management. When you look through the literature and the data in regards to hip and knee replacement, in regards to blood management and blood loss, there's a substantial amount of blood lost in these two procedures, at least in the literature, that is. Anywhere from 300 milliliters up to a liter, and even as high as 2 liters of blood can be lost from having a hip or a knee replacement. So that's a substantial amount, and that usually results, when you get between 1 and 2 liters, it usually results in some type of necessity of the possibility of transfusion. Obviously, the more you lose, the higher the percentage is associated with that. Studies show that when we start off a little bit lower, a normal hemoglobin is anywhere usually over 14 grams per deciliter. When we get down in between the 10 to 13, that percentage goes up significantly, usually for the need for transfusion. So obviously anemia plays a huge role in this, and as we get older, anemia actually plays a huge role in our lives as well. It's just a natural process that we do become more anemic throughout life. And obviously, those are the times when we normally will need joint replacement or other orthopedic procedures. There are substantial issues involved with transfusions. We have heard many of those, but transfusions have a significant cost to them. The average allogenic transfusion, which is blood from a donor, costs about $500 for 1 unit of blood to process it, to get it ready, to store it, and to deliver it. Autologous donation, or donating your own blood and then receiving that back, is about $600 per unit. When we use certain saving measures during surgery, such as something called cell saver, which reprocesses your own blood and gives it back to you. That's as high as $800 to $1,000 per surgery, and usually that's about a unit. So these are substantial costs when you're talking about millions of people that are having this. And even if in the next year, out of the 1 million people that were to have hip replacement or knee replacement, if 25% of those individuals were to have 1 unit transfused, it would cost the healthcare system, approximately $125 to $150 million more dollars. So it's a substantial cost. And obviously, we all know that cost is a major issue with Medicare and with our health system today. So just from that perspective, it's a significant issue. We also have significant problems with transfusions, such as postoperative infections, delayed recoveries, longer hospital stays, and increased mortality. These are tied directly to the need for transfusions. We also, from the transfusions themselves, can have inherent infections or contaminations, immunologic modulation, or immunologic reactions to the unit. No unit of blood that we receive is going to match you perfectly. The only one is yourself. We also have strong religious convictions and individuals that, for religious means, do not want to have any donated blood or allergenic blood given to them at all. So that's a consideration that we have to take all the time. So there's 3 different ways that we can approach orthopedic patient blood management. Obviously, they're simple: before surgery, during surgery, or after surgery. Each one of those have their inherent issues that we need to deal with. So I'm going to talk a little bit about before surgery. The goal of a patient blood management strategy is obviously to maintain the patient's highest hemoglobin. We just heard there's a direct correlation. We want to keep our patients that are going into surgery as high as possible. We have talked about a transfusion trigger that all of us were taught in medical school and in our training, that if we have a hemoglobin of 10 and a hematocrit of 30, that anything below that we should automatically transfuse. That is changing dramatically. I've had the opportunity of working with Dr. Tibby, and about 3 years ago, he came to me and said, "Hey, how would you like to be our orthopedic blood management champion for YRMC?" And I kind of looked at him and said, "What in the world is that going to involve?" You know, we are all taught these certain things throughout our training, and oftentimes we don't question them. We question the authority of our trainers and our attending physicians that teach us this, but oftentimes we don't have the time, we don't have the resources to really dig into it and learn about it. So he started explaining this to me and telling me a little bit more about this, and giving me some literature, and Dale Black gave me some literature, and I started reading this and going over this, and then we started playing with this a little bit and implementing this. It's all evidence-based data and proven things. So we don't follow this transfusion trigger anymore. We do this based on the physiologic assessment of the patient's response to anemia. Every one of you will respond differently to anemia. Every one of you. Sometimes, some of you right out there right now probably live at a very low rate, even a 9 or 10 hemoglobin. And you are just fine with that. You adapt to that. Your body adapts to that. And so every one of you are going to be different going into surgery. So obviously the most consistent predictor is to keep that preoperative hemoglobin up. About 3 weeks prior to the procedure, we like to evaluate our patients. We normally get a baseline laboratory test to get the hemoglobin, and from there we look at 3 different interventions. We look at vitamin supplementation, we look at something called epoetin alpha or Procrit, which is a synthetic erythropoietin, which is a hormone that is produced in the kidneys to help produce and increase the red blood cell count in our body. We also look at something called preoperative autologous blood donation. That has kind of fallen out of vogue, and I'll talk a little bit about that. The vitamins that we're concerned about 3 to 4 weeks ahead of time include iron. We've talked about that, the difference of oral iron that we can take in, and it's really not absorbed very well. It's usually not accepted very well. We have intravenous iron that's a little bit tougher to have access to, but it's much more effective. Simple vitamins like folate, your B vitamins, and vitamin C. All of these will help kind of buoy up the blood system, but it doesn't make significant changes, and it doesn't do it very quickly. And it also depends on if they're deficient in these as well. So obviously we like to start that 30 to 45 days before surgery to kind of help that anemic situation. You do have specific side effects with that, like you would with anything, including constipation, heartburn, and a difficulty tolerating it. Another regimen is Procrit. That helps stimulate the red blood cell production. It's usually effective also about 30 to 45 days ahead of time, but at least 3 weeks. Certain insurances will pay for this, not all of them do. It's a pretty costly intervention, so unless we absolutely have to do it, we normally don't go that route, but the ones that are optimized with that are the patients between 10 and 13. So we can kind of help build that up significantly over about 3 weeks.